Hi, my name is Teresa Lugatiman, and I'll be doing joint mobilizations for the shoulder, the elbow, and the wrist. The first mobilization that I'll be demonstrating is on the shoulder, given that the patient has 90 degrees flexion and 90 degrees abduction in stiffness, more so than pain. The patient should be supine, and the therapist position should be facing the patient with the right hand supporting the patient's right arm and the left hand over the glenohumeral joint where grasping the humeral head. So direction of force is downwards into to create an abduction, to create more abduction for the shoulder. So we'll be doing grade 3 mobilizations, 10 of them. The next mobilization that we're doing is towards glenohumeral extension. I'll be facing the patient in supine. My right hand is supporting the patient's shoulder by the acromion process to keep it from touching the treatment table. And the direction of the force is coming from the left hand of the therapist, pushing downwards to the floor, creating an extension movement. So, the next mobility that we're doing is longitudinal caudal movements for shoulder flexion. With the patient supine, the therapist has to support the patient's arm with the right arm.
No, I'm not going to do that.
The left heel, the therapist's hand pushes the humerus downwards.
Great. How are you?
I don't know as good as I did today.
And if we can, carry it towards more flexion and add more force.
I know, I tried.
The next movement we're doing is anterior-posterior movement in abduction, 90 degrees for horizontal AB or adduction. So the patient is in supine position with the arm at 90 degrees flexion, 90 degrees abduction. The therapist is facing the patient. The right hand supports the therapist. The right hand of the therapist supports the patient's right elbow, and the left hand, which directs the force, has to be over the humeral head, with the direction of the force going downwards. The next mobilization we're doing is to create a pronation motion. The patient is still supine and the therapist sitting right beside the patient with the elbow held or supported by the right arm and hand. The left hand is going to find the radial head, and the motion is going to be towards upward and into medial. The next mobilization we're doing is to improve elbow flexion. With the patient supine, the therapist can sit with the patient. The elbow is cupped between the two hands, and the thumbs are placed anteriorly over the elbow joint. So for accessory movement, there's going to be a distraction force applied and an anteriorly directed force to create a flexion towards create a flexion motion. So The next mobilization we're doing is anterior posterior movement of the radial ulnar joint, the superior radial ulnar joint, because this might cause pain in supination. So the therapist supports the patient's elbow or forearm with the hands, and the thumbs are placed over the radial ulnar joint, right here. The therapist has to apply enough pressure to have the thumbs sink into the muscle to move the head of the radius.
Activities room.
In grade 1 mobilization. Now we're doing mobilizations for the wrist. The first one is radiocarpal anterior posterior movement to increase flexion or extension, and in this case both are limited to 15 degrees. There is more stiffness than pain. The patient is supine, the arm is in neutral position, the therapist faces the patient with the right heel over the wrist of the inner part of the arm, the left hand over the wrist on top of the hand, and oscillations are done pushing on the heel of the therapist. Wrist mobilization to increase supination is done with the patient still supine, the forearm in midline pronation supination. The therapist's right hand is over the first row of carpal bones with the index finger around the triquetrum. The left hand is on the wrist, and this serves to limit movement. So movement is done by the right hand towards supination. Hi, today I'm going to show you how to improve flexion and extension as well as radial deviation of the wrist in accessory motions. So to create a flexion movement, increase flexion movement in range of motion, the patient is supine. The therapist can kneel at the side of the bed, holding the patient's wrist with the arm or with the hands, and application of force is through the thumb. To create a flexion force, we have to create a slide towards a dorsal slide, or an anteriorly directed force to create a roll of the metacarpal of the carpal joints anteriorly. To improve extension, the slide has to be applied towards the posterior direction, or from the posterior direction. And you can feel that the glide or the slide is going anteriorly towards the wrist. Radial deviation can be done with a therapist still supporting the wrist and creating a distraction movement